I set up this public health comms hub as a place for us to come together, solve problems, share learning, and also to share some good practice. If any of you have got any suggestions for anything that you think we should cover with one of these webinars, one of these free webinars in the future, please do put it in chat, and we'll think about it and try and do it if we can. Also, if you've got any questions for myself or John Paul, put them in chat and we'll try and bring them into the conversation later on, try and cover those. Just so people know, we're recording today's session. If you prefer not to be in that recording, I'd say keep your camera off. We will share the recording with everybody who attended today and everybody who is signed up to the Public Health Comms Hub afterwards. Just to introduce myself a little bit. I currently split my working time. I'm Assistant Director of Communications and Engagement at NHS South East London ICB. And I've worked in NHS comms for the past 23 years. In the last 5 years, I've become a bit of a behaviour change specialist and learnt a lot about behavioural science and how it can be used to have real impact on public health. So I'm now also working, and I said I split my time, I'm now also working as a consultant to train and support other in-house teams to incorporate behavioural science into their ways of working. So that's a little bit about me. This hub and these sessions are only possible due to the great support that I get from Can Digital, and I'm running this session not just with John Paul, but also with a great behind-the-scenes team. So I'd like to thank them, but also ask John Paul to introduce yourself, please.
Hello, everyone. For those that know, I'm John Paul from Can, and we help the public sector run campaigns across all sorts of areas, but have run a lot around vaccine, MMR and COVID, which I'll be sharing some of the insight from with you later on. And our objective is to reduce cost per outcome. So we're designed and honed to make sure that you get as many measurable outcomes for your budget as possible. Thank you, Russ.
Thanks, John Paul. Okay, so today's focus is on two very current vaccination challenges that those of us working in public health comms face. So we're talking about boosting uptake in MMR vaccines amongst children and also young adults. And we're also talking about spring Covid-19 boosters amongst the eligible cohorts. And I want to start with a little bit of a caveat. These are both tricky challenges in the current environment. Both of them are far from easy. So we're not going to pretend we've got all the answers. Hopefully, we'll get some answers from you as we go, and we will be sharing some insight and discussing some, looking at kind of what we know has worked previously and what we might, come up with ideas and looking for ideas where we can maximize our impact in these areas. So first of all, I'm going to set the scene a little bit, or attempt to set the scene. So regions are tasked with rolling out COVID-19 spring boosters with those eligible people. So those of you who don't know or need reminding, it's people over 75, those who are immunosuppressed or living in a care home. Now, this, in some respects, is quite a difficult group to target. Many of them will have received or been offered 5 or 6 doses of the vaccine previously. And we know that attitudes around COVID-19 and attitudes around vaccines generally and the COVID vaccine have shifted quite a lot as time has gone on. We're definitely in a different place to where we were a few years ago, where we first started COVID vaccine comms. And when we rolled out the vaccine to all adults, at that point we had, a lot of us had big budgets, budgets of the like we may never see in the NHS or in public health again, sadly. And we tried and did lots of innovative things. We started using lots of new channels, new activities, different things that we'd never done before. And there was a lot of kind of creative work and creative thinking that went on there. The reality now, though, is that sadly we don't have those big budgets, or most of us don't. So I think it is really important that we analyse what did work, and that we so that we can inform where our efforts are with the small budgets that we've got, or the no budgets that we've got in the worst case scenario, so that we can try and get the most impact with what is available to us, really. So I'd now like to ask you what you've previously done to amplify your vaccination campaigns. Thanks, JP. You beat me to it. I was just about to ask you to start that poll. If you could all fill that in, please. If you could answer honestly, don't restrict your answers to COVID vaccination campaigns or MMR, if we talk all vaccination campaigns. And yeah, just which of those channels have you used previously to try and amplify your vaccination campaigns? I'm quiet because I'm actually answering it myself. There we go. Okay. Yeah, we'll come back to those answers in a little bit. So while you're doing that, I'd like to set the scene a little bit around MMR. And apologies, some of you will know this, but just as a bit of kind of context setting, uptake of 95% of the vaccine is needed to protect the population and in most places a first dose is offered at 1 year and a second dose is offered at 3 years and 4 months. Now, in recent years, uptake has fallen considerably and is currently at the lowest it's been for a decade. First dose has fallen nationally to 89%, and uptake of the second dose has fallen to 85% by the age of 5. And without this 95% that I mentioned, serious diseases like measles can take hold. And, we saw earlier this year outbreak in Birmingham and the West Midlands, and numbers and outbreaks in various parts of London and other parts of the country as well. And that was serious enough for the UK HSA to declare a national incident. So clearly MMR is a big priority for us all, and we're all being asked to do work to increase uptake. Just thinking about kind of why some of that happened. So we know a big influence has been Andrew Wakefield's now very much discredited link to autism that he made in a paper that was published 25 years ago, and that continues to impact uptake now, sadly. I think it's also been given a bit of a further fuel almost, because since he first made that claim in the discredited paper in 1998, it's correlated with a massive increase in diagnosis of autism. So since that time, diagnosis of autism has increased by 787%. Now, clearly that isn't because of MMR, it's because of greater awareness, it's because of more understanding of autism as a condition, more staff in positions to be able to diagnose, and also more parents seeking diagnosis as well for their children. However, I think people have made that link, and I was looking at some insight documents produced the other day, and focus groups carried out across the country, it came up as a thing. Lots of people said they had a child who'd received a diagnosis of autism, and they were told by somebody in their community that was because you gave them the MMR. So that link is still there 25 years later. So we also know that satisfaction with the NHS has fallen considerably. So there was a peak in 2014 of 65%, and last year it hit a low of just 24%. And actually, in the last 3 years, that drop off in satisfaction with the NHS has been quite dramatic. So 29% has fallen. And I I do think, in my opinion, trust and satisfaction, are intrinsically linked. So I've trawled through some research and insight. Some of it was carried out by NHS England, some of it was by other organisations. I'm just going to quickly go through some of the insights that struck me whilst going through that from what people's attitudes towards MMR. So generally, there's overall positivity towards vaccines. Sometimes this is a bit lower when it comes to MMR. Than other vaccines, but general overall positivity. Lots of people cite when they're talked to, when they have discussions around it, that they like to make informed decisions. They like the information. They like dialogue. Discussions amongst parents and grandparents and things like that. There is quite a lot of a lack of understanding of how vaccines work. This is quite common. So there is definitely some need for more kind of comprehensive education on the science behind the vaccines, potentially. Something that continually kept coming up with all sorts of different community groups is storytelling, using storytelling to cover how vaccines have saved lives and eradicated diseases. Interestingly, bearing in mind what I just said about trust in the NHS, dipping right off, healthcare professionals, especially doctors, remain very strong, trusted sources of information. Them plus, I think, faith and community leaders are very much trusted based on the insight I've been looking at. There are clearly there's lots of correlations and lots of kind of things that occur in all or most areas, but also there are definite regional variations in knowledge, understanding, and perception. So it is really important that you do and you look at what local insight you've got, and maybe develop your own local insight. Some of the barriers that were identified, so there were more around things like travel time, cost of travel, transport links, and access to healthcare facilities generally, in lots of respects. Quite a few people cited, and this is more operational than comms, but cited clinics where parents could take more than one sibling, for catch-up jabs, as something that would be helpful. Interestingly, social media is not considered a reliable source of information by lots of people, and many people acknowledge that it can be used to spread misinformation. And I think actually in the last few years, I think we've seen people's perceptions of social media change a little bit. And I mean, personally, I've seen strange things happen on Meta, so on Facebook and Instagram, that you probably weren't seeing a few years ago, and obviously the decline of X, or Twitter as it was. So it could be that actually, if trust in those channels generally is quite low, maybe they aren't always the best place for us to place their adverts and place their posts. I'm not saying we shouldn't use them at all, but maybe they aren't the place for all of our efforts. I don't know. I think the other thing that came out as well is that communications can't be the answer to everything. And a really strong point was the importance of consistent and ongoing engagement and outreach, not just relying on communications, using the two to complement each other. That's the... Oh, I think also there is the looking at MMR insight, the COVID vaccine came up regularly. So I think the COVID vaccine elevated the kind of profile of vaccinations generally. And with it, we've seen, especially since we've seen an increase in anti-vax sentiment, alongside the decrease in trust for the NHS, and also some of the behaviours of government and the NHS being seen as a bit of an extension of that. I think that's the main kind of points that I pulled from the insight work that I did. I think the key thing when planning vaccination comms, especially at the moment where budgets and time are stretched, is what has actually driven people to take action. So I'm going to bring John Paul in now, who's going to share another piece of insight.
Thank you, Russell. So I'm going to try and, well, I have already trawled through a lot of the work that we did around COVID, around vaccination, and a lot of the work we've done around MMR. And I'm going to try and give you the benefit of the experience of doing those things. I think part of the point of this group is that we help each other and help each other benefit from each other's experience. And Can has a fairly unique perspective from having worked on many hundreds of these sorts of campaigns. I think now, much more so than during COVID, we need to get a bit laser focused on what works and what doesn't. And that there just aren't the resources to invest in things that don't deliver a correlation in terms of jabs with arms, jabs in arms, sorry. And I was struck by this quote from a former head of MI5 on the Rest is Politics podcast. And I think it's very, very applicable to much of what we do. I just wanted to launch another quick poll, if that's all right. We've tried a lot of different things, and I wondered if anyone here has tried something and they've seen it work and deliver a very convincing correlation with an uptick in jabs in arms, because we've had varying results from that. So please pop in just free text anything that you've seen that's working, because obviously we're not the front of all knowledge, just the things that we've done, and it'd be great to share there. So I'm going to quickly whiz you through channel selection and maybe how to do that a little bit better. Some approaches to planning campaigns that I think are useful and have worked well in other locations. Some data around targeting specific communities and ethnicities, and maybe a little challenge around that approach. Approaches to general messaging, what we've seen working and what we know works less well, and some tactics that we've tried in a number of places for people who have little or no budget, which I believe is generally the case. We'll also be looking into some search insight around general immunisation and sharing that with you. So often bring this out, we'll share this afterwards, but it's a way of looking at the various strengths of different sorts of channels. We have at the top there the owned channels of the public sector, particularly councils, email and website. Now those are free, but they have strengths and weaknesses as well. And then looking at the array of paid channels that you can use to amplify messaging, again, it just sort of helps you take maybe stakeholders who are asking for specific channels through a decision-making process and enable them to compare what might happen maybe with radio and out of home, and why it maybe doesn't work quite as well as other channels. But we've certainly experienced being asked to place media on radio, and we can tell that the cost per interaction is very, very high, and the correlation with even web traffic, let alone jabs and arms, can be quite low. It's not that they don't have a place, it's just that you need to consider they're expensive. Also, many councils are able to use out of home for free and maybe have PR and sort of content relationships with radio stations. In those instances, it's brilliant. It works well. But when you're spending £1, you need to make sure you can measure the biggest bang for that. Biggest bang for that buck. Also, it's really worth, when you're planning, Facebook, Instagram, and Google activity, being aware that last month Google put in new policies around anything to do with health, which means that you can plan, but then when you put your content onto, for example, YouTube or into search, or try to push something on Meta, you might just get blocked. And Meta is particularly unpredictable at the moment, so it's worth considering a wider array of channels, Snapchat being a good one, and news platforms like Quantcast, which which have, in my opinion, slightly more sensible approaches to this. So that's new for now, and worth considering when you're choosing channels. one thing that we can see from the data as well is that short bursts of activity do almost nothing. Here we've got some data from a campaign where we were correlating communications activity with jabs in arms. And you could see it was actually a sort of a bit of mistake on a social media platform's part. But then we created this huge spike in campaign interactions. And you can see the blue line to the right. There was no correlating increase in uptake of vaccine. So I think you can use this data to say, look, we should be looking at gentle, always-on approaches to addressing this issue, and not what we term here as too little, too late for 2 weeks. Not reactive. Take your time, plan, and then plan to be delivering messages to audiences over months rather than weeks. And that's the only way to really deliver a sustained change in behaviour. We are often tasked with targeting specific communities, and there are very neat and efficient ways of doing that. So contextual targeting, where you might be targeting sports and cultural content from specific countries being consumed in a certain geography in the UK. And we've used these tactics in the past to great effect. Also, the ability to target people not based on a geographic area that is that might have areas of deprivation, but actually be able to target people based on their household income. And that approach, again, is also very efficient. Now, during the vaccine rollout, we ran promotional campaigns using lots of different creatives in about 44 different locations across the UK. And we were asking people that interacted with that campaign how likely they were to take the vaccine, because we were being told to use a phrase that I believe has been moved away from now, to target BAME audiences. And I just wanted to show you something that was quite significant. So everyone was asked 1 to 10 how likely you are to take the vaccine against COVID. Now, we obtained from various tactics 10,000 responses from low-income households and 16,000 responses from specific communities that we were asked to target. And we actually found that propensity to take the vaccine amongst specific communities, if you targeted people based on their ethnicity, was higher than the national average. Whereas if you targeted people based on their household income, you found that was where there was more reticence around the vaccine. So be careful when you're being asked to target certain communities. That's good, but in terms of where you're putting messages, it's probably more to do with household income than it is to do with the community that you come from. Now, in terms of messaging, that's a different kettle of fish altogether. But challenge it where we were in areas, locations that had low amounts of diversity, i.e., high white populations. It was definitely indexing with low income, and so we're able to see in one massive campaign in lots of different locations that data, with fairly high sample rates. So if there's one thing that we would recommend considering is that the data at very high samples showed us that to be the case. Just wanted to talk about now when we're targeting messages. One thing that really does not work particularly well is simply re-amplifying national messages. Localizing and mentioning places very near to people and delivering, for example, clinic or pharmacy opportunities very, very close to individuals where there's a place or a high street that they'll remember worked very, very well. Also, mentioning locations and the specific provision in the ad made those ads have much, much higher interaction rates. We also amplified a lot of creators like this. So this was a Ghanaian nurse talking about taking her elderly relative to have the vaccine. And that was positioned alongside sites like Ghana Web being consumed in specific locations. But I would again say it's not so much that you need to have people reflected by people who are exactly like them. It's much more that you need to have voices from the community that they are familiar with, which will be the wider community, the sort of the location-based community. That works absolutely fine. So this person indexed particularly well with all sorts of different ethnicities, not just Ghanaian. So reflect your local community, not so much mirroring the communities of the people that you're trying to target. I'm just going to move this on. I also wanted to show something where you've got a situation where people are definitely, probably definitely aware that vaccines are available. And we're recommending an approach whereby you would use choice architecture. So in this example, we're targeting parents, and we're talking about protecting your family's health during the winter, for example. And then we give them an array of things they can do to protect their family's health. And the theory behind choice architecture is that if you give people an array of choices, the net number of choices goes up. And I think this overlaps quite nicely with this idea about general health promotion and seeing vaccination as an approach. And then, of course, by giving people these options, you can firstly see what people are thinking about and get a sort of an outcome measure of levels of awareness. But based on what they're interested in, you can then serve them or curate different sorts of information to put in front of those people, and then to potentially to remarket to them over time. So consider using choice architecture. Building forms like this, very, very simple and very effective in terms of getting measurable outcomes from what you're doing. So another sort of top tip there. Wanted to talk to you as well about considering you need to run campaigns in a sort of always on type fashion and don't have mega budgets. Using tactics like placing free advertising around school term dates pages on council sites is one of these golden tactics, which means you're getting in front of a lot of parents quite frequently and able to get an array of messages. This could also work for HPV. It could work for different sorts of things. Looking at adult social care content on council sites and placing ads around taking, the 70+ audience to get spring booster could also be powerful. In the absence of large budgets to buy radio, TV, and out of home and things like that, using your email bulletins, again, at the council level, these are often opened and consumed in much larger numbers than local newspapers. And they are an incredibly efficient way of generating ongoing interaction and awareness for very small amounts of money. Well, for free, in fact, but with very small amounts of money. We thoroughly recommend you imagine someone that's been to the school term dates pages and accepted cookies, the ability to then place messages as they go onto YouTube or go onto news sites or even go onto Meta and nudge that audience. It's incredibly efficient targeting, because rather than buying third-party data that someone's a parent, you use the public sector's own data and then are able to remarket to people based on that. And that, again, can be sustained in relatively small volumes with small budgets over a long period of time. So the general sort of summary to surmise what I've put across there is that when you're selecting channels, really focus on programmatic, targetable media. That way you won't be spending money advertising to the wrong audiences. Aim to have always on approaches. Make sure your plan is over months, not necessarily weeks. And when you're targeting specific communities, consider the low household income, household incomes C2D sort of range, because it may be that actually the resistance or the hesitancy to, or actually an inability to prioritize health is actually what's standing in the way. Making sure that messages and approaches are localized, reflect the entire community, and maybe focus on choice rather than confrontation could be a neat and effective approach. Make use of these owned channels and retarget using your own data can make very small budgets go an incredibly long way. I also wanted to, sorry, I did position Search Insight as well in this. So I'm just going to quickly take you to that. Now, what Search Insight helps us do is see in any given area, we can look at historic search. So in, by month, this is the volume of terms of people in a specific location and what they typed into Google. So we can look at, for example, search terms around childhood immunization, MMR and so on. We can also look at flu, and I assume that this is when the NHS, the public sector, is communicating about flu jabs. You see a reciprocal spike in interest amongst the public in that subject. You can see here searches around various terms around specific vaccines and how those trended in any location. People also looking at side effects, and I think you can start to see that it gives you a window into what is on people's minds, but also what's not on their minds, or what is declining in terms of trends around search. And we can look in specifically at MMR. And so the reason I'm showing you all of this is it helps us contextualize what might be the areas that we need to raise awareness, or the areas that we need to stimulate active consideration around certain subjects. The idea that people are concerned about certain topics, we can check in your area whether people are searching for those terms. And anyone in this group is allowed to just drop me an email, and I'm more than happy to do a specific array of search for the location that you're in. And another, I was just thinking earlier on about the presence of less than helpful information. There's nothing stopping you from accelerating the viewing of scientifically approved information that doesn't necessarily come from you. Scientific, easy to understand animations around vaccines and helping educate people around something which is not a simple subject could also be a very neat tactic. So hopefully that was useful. We'll obviously share all those slides with you afterwards, and I hope that some of that is useful, and do get in touch if you'd like to have that search insight for your area. Back to you, Russell.
Yeah, I think let's so I can see there's one question in the chat which we'll come back to in a moment, but if anyone else has got any other questions, please do put them in there. And then while you're doing that, I think we should have a quick look at the poll results. So just looking at the first poll, and I'm not sure that we can put it on this. Do people need to click on it themselves to put it on the screen? They do, don't they? I think. But I can talk you through them anyway. You should see it in your chat. So there's quite a lot of use of paid social media, which is the highest out of all of the different categories in that for channels we've used for Vax stuff previously. Out of that's 18% of people of you answered that. Out of home is quite big, and I would say, out of home for me is I'm not a big fan of out of home at all, and the main reason for that is I think it is incredibly hard to measure. I think it has its place. I think it works very well for big corporations, like Nike or whatever. And there is that almost like subliminal taking in of their messages that you also consume from elsewhere. For a local campaign, I really don't advocate it at all. That's to say, unless it fits into the category of your local armory, so if your council or your partners have free or very cheap access to out-of-home advertising, it's definitely worth doing to supplement other activities, but I wouldn't plow all of your money to it. It's just not, it's just so hard to measure, and I think the impact is often minimal. Online news and radio, both up there. Again, radio's difficult to advertise, and as JP was saying, the reach of online news and local news varies. Often it's similar to a similar reach to kind of an organic post on a social media channel. Not that many of you search advertising, interestingly, because that is something which I think, and I haven't used it that much myself, but I do think, especially if we're talking about always on campaigns for things like MMR, that has to have a role, surely. TV, relatively low numbers. Print advertising still used and did have a bit of a resurgence during the pandemic. Print. Online communities, Facebook and Nextdoor, sort of 10% and 7% YouTube. So that's interesting. And a lot of you filled in that survey. Then we asked the more direct question, which was around what tactics or channels specifically increase jabs in arms. And interestingly, quite a lot less of you answered that question. And I think that is there's no judgment here. It's always hard to measure what actually drives jabs in arms. That's not to say it can't be done. And also, I do know, particularly a few years ago, we were being told to do stuff and do it yesterday. And that often meant it was difficult to plan a thorough evaluation into that. But I think it is where it's helpful to have things like John Paul's experience and the data that he's got to be able to show us some examples of things that did work. So the thing that quite a lot of people said was clinics, and we were all involved in local clinics and pop-up clinics, or the comms around them, or the engagement and the community engagement and community trusted voices are in there, as I mentioned. So, just going back to my earlier point, really around comms not being the answer to everything, but comms being a really good supplement to some, out on the boots on the ground type work, where you're out and about developing and nurturing those community links and community connections. So yeah, let's have a look at some of the questions, and I can see there was one that came in specifically for you, John Paul, which was, have any councils or GPs tried the mini health survey approach?
Yes, that one I shared with you was Redbridge. They have, and a couple of other locations, I believe Barnet and potentially Wigan as well. So it's useful, I think, in a number of ways. Yes, it gives you a survey, an idea, but it also creates a user experience. Many public health campaigns unfortunately suffer from the landing page being slightly less than fizzy, should we say, and triaging people in the middle with something that shows you're trying to tailor content to them, and then landing them in the place that's useful based on what they've told you, increases engagement, increases dwell time, and makes it, I think, a little bit less broadcast, a tiny little bit more of a conversation. So we see interaction rates go up. And also we know that we're then giving people information that's going to be useful to them. Unfortunately, it's often a huge challenge to then get the business intelligence, the data at the other end, to see how those two approaches differ. But at least we get that interim measure, so we can show people that people are interacting, they're feeding this back, and also that data then helps us shape messaging for the campaign based on what people are telling us. So you can have updates to messaging over long periods of time that then perform better, because that's what the audience are telling you they want. That's another advantage to having longer, always-on campaigns. They can evolve and reduce cost per measurable outcome over time.
Thanks, John Paul. There are any more questions, please put them in the chat. But just building on that point, I mean, I think, so not specifically the kind of survey approach that John Paul showed, but the way in which you present your, what we call the choice architecture, is really so important in terms of driving people to take action and change their behavior. I've run campaigns previously where, for instance, one campaign, we had some really engaging creatives that we were testing, and we were getting a really high engagement rate. So lots of people were clicking on our adverts, and we were taking them to a page that was on an old CCG long gone now website, which was very sterile. It looked like every other NHS website, and it was a huge leap from this really engaging advert that caught their eye and got them to try and think about taking the action we wanted them to take, to then all of a sudden, and it was a mental health campaign, all of a sudden they'd gone from something that really, you know, caught their eye, got, you know, yeah, I'm actually interested in this, to then all of a sudden they're in an NHS, you know, white and blue website, which, you know, they probably thought, I'm going to get sectioned if I carry on with this, you know, and it was all about mental well-being. And similarly, I've done stuff before where actually, you know, you're not quite getting, if you measure what people do when they come to your website, and you realize actually we're not quite getting the same amount of interest that we want, or people aren't clicking on it, taking their key calls to action, even just by changing the order of things and putting, you know, the stuff in different places and changing the words that you put around them, you can really drive action just by, you know, some really subtle changes and testing the impact of those. So that choice architecture is really important, definitely.
I think, Russell, as well, speaking to Louise's point earlier on about a future session on the language and the copy that we use, I think that there is so many easy wins there. It's often overlooked. We're thinking about, let's get to everybody and let's get that message many times and then let's bring them through to something. But in terms of delivering measurable outcomes, those little nuances that you were referring to, I think can treble, quadruple measurable outcomes as a result. And that would be a wonderful thing. So thank you, Louise, for that suggestion.
I can't see any more questions. So I will just do maybe a quick summary of kind of some key points, I think, from today. I think, you know, from my perspective, what I heard and what I got is, I think planning ahead, making the best use of yours and your partners' own channels, you know, is a really good way of making use of a small or no budget. You know, they often have bigger reach, especially the council ones, bigger reach and more readers than your local news outlets, which we probably, in the NHS anyway, we're probably guilty of putting more effort into. And also they potentially bring opportunities to remarket at little or no cost. So definitely have a look at that. Try and avoid what I call some of the vanity channels, which are expensive and hard to measure, and often deliver very little. And, you know, out of home could be one of those, you know, bus adverts. Radio and Spotify, we've yet to see these working, and that's not to say they haven't in some examples, but I haven't seen examples where they've clearly driven action. Don't just focus on Google or Meta, as John Paul said. And I think, you know, yes, you can use other things to measure, but your key measurable for any vaccination campaign has got to be the numbers of jabs in arms and how that's driven. You know, it's all very well saying we reached X million, or, you know, we had this engagement rate, but actually if your jabs in arms don't increase, then yeah, it's doing nothing. Supplement your communications with engagement and outreach, and that may not be your team, but, you know, link in with whoever might be able to do that, and make sure that you're working together and joining up. An interesting one that came from John Paul was to focus on household income or deprivation rather than ethnicity, but when you're doing that, obviously make sure that your messaging is appropriate and, you know, and meets the needs of the populations in those areas, I guess. And then I would say also, don't just amplify national messaging, localize it where you can. And again, going back to my earlier point, just to, you know, and what John Paul was saying, just a very minor tweak. You know, if you're going to use national, just make sure you localize it a little bit, refer it to, you know, what's happening in your area, you know, put some text in that refers to the place where you work or where that clinic is, or, you know, just so that people know it's not just something that's come down from government where we know that trust is low. Thank you very much, everyone, for joining. Please do keep an eye out for the future webinars.